Around the globe, the devastating impact of climate change is increasingly clear. What may be less obvious is that it is also making us sick, some of us even more than others, by contributing to more disease, asthma, heat deaths, and mental health impact. But there are things we can do to address the climate crisis and improve the health of those we love, our families, and our communities. Today, climate and health champions join us around the table, and together we'll chart a path forward for better health for all. Welcome. I'm Dr. Kurth, President of the New York Academy of Medicine. Thank you so much for joining us today. The climate crisis is a health crisis, and it's been called by many the public health crisis of our time that we're facing. It's happening now. It affects our human and community health everywhere, though not equally. There are things we can do, especially as public health and healthcare workers. So today's discussion is going to focus on populations and communities, highlighting the impacts of climate change on structurally marginalized communities, often affected first and worst, including related population health impacts such as increased levels of illness, for example, asthma, amongst children, the loss of housing due to catastrophic weather events, the effect of heat waves on aging populations, and the need to address climate justice always as we work towards health equity. Today, we'll hear from two superb public health leaders, Dr. Georgia C. Benjamin, Executive Director of the American Public Health Association, the APHA, and Dr. Ashwin Vasan, Commissioner of the New York City Department of Health and Mental Hygiene. Dr. Benjamin has for over 2 decades led the APHA. It's the largest professional organization of public health professionals in the US. The APHA has been involved in every major significant public health initiative of the last 150 years. Dr. Benjamin previously was the Secretary of the Maryland Department of Health and Mental Hygiene, and he's a board-certified internist. This year, he was voted one of the top 500 most influential health policy leaders in the US. Dr. Vasan currently serves as the 44th Commissioner of the New York City Department of Health and Mental Hygiene, a physician epidemiologist trained in economics from Harvard, with his MD from the University of Michigan and a PhD from the London School of Hygiene and Tropical Medicine. Dr. Vasan is also a practicing primary care physician at Columbia. In 2016, he started the first Health Equity Access Unit at the Department of Health and Mental Hygiene. And before that, he worked globally at Partners in Health and the World Health Organization. We're pleased to have Dr. Vasan as a very valued member of the NYAM Board of Trustees. Both guests have outlined strategies around climate change in public health practice, including at the APHA, creating the first center on climate change and health equity. So who better to explore the role our public health professionals must play to address climate-related effects on our community's health? I look forward to the conversation and sharing with you all. So welcome, Drs. Benjamin and Vasan. I am so grateful to have you here and thrilled to have you joining us. Both the American Public Health Association and the New York City Department of Health and Mental Health, of course, have been out there for a very long time with warnings and messaging and education about climate change, conveying that it's both a public health and an equity crisis. So how do you each approach addressing this very real, very timely, very significant crisis through your work? We're going to launch into that in a little bit of depth. Why don't we start with you from the local perspective, although we often say New York City is the world, of course, but Ashwin, what are you seeing and putting in place on the New York City level that's most directly impacting the health of our structurally marginalized populations in particular and communities who are, as we know, often most affected by the climate crisis?
Thanks. And first, let me say thank you for having me, and thank you for having the department represented here. You know, environmental health has been a core pillar of our work for 2 centuries, the 2 centuries of the Board of Health that then grew into the New York City Department of Health and Mental Hygiene. And so it's wonderful that we're talking about it today. And as you said, you know, New York City is both a local health department. We are also kind of a city state in and of ourselves. And often the crises that we face as a country or as a globe land on our doorstep, as we saw with COVID, and get amplified in part because of the density and inequity under that density that the city experiences, combined with the eyeballs of the world on this city. And so we have innovated a lot, we've grown a lot, and now we're confronted quite real and quite directly with the effects of climate change. And this is coming on the heels of a major hazardous air quality event that landed on my portfolio and my doorstep just a couple of weeks ago, where the entire city's eyeballs were trained on public health, looking for guidance on whether it's safe to go outside and what's going to be the effect of this air quality on my health, and what about my loved ones who are vulnerable, or my children. It had many of the echoes of the early days of COVID, because there was anxiety and there was fear. And once again, for that 72-hour period that we were dealing with this, public health was in the crosshairs, where our voice as an agency was front and center in saying, these are the things that we need to do to keep ourselves and our loved ones safe. The events of a couple of weeks ago make it plainly obvious that climate change is real. There is very little to distinguish local environmental health efforts and global climate change efforts, because they're all connected, and that events thousands of miles away can land on your doorstep in a matter of hours and become extremely salient for your life. And so if there was any outstanding question about that issue, last week or the last couple of weeks brought that home to roost and to bear in the largest city in the country. Now, underneath that, of course, is who's impacted. This was a relatively no notice, as we say in emergency planning, a no notice event, but a universal exposure, right? Normally when we have no notice events, we have a fire somewhere or a burst pipe in a flood somewhere, or we have something, but this was everyone. Every single person walked outside and breathed that acrid smoke. And it wasn't like a pandemic in that it didn't roll out over time. It hit us all at once. It was a point exposure. And so how do you think about pre-positioning assets like masks, like communications assets, like real clear guidance on air quality indices and how to take precautions, in particular in communities with poor underlying air quality due to environmental racism and structural inequity? So these are all huge questions we're wrestling with as the health department of New York City. And I think public health leaders across this nation and the world are going to have to wrestle with this increasingly so.
Absolutely. Yeah, well said. And thank you for that broad perspective. Dr. Benjamin, along those lines, of course, APHA has been working on these issues since the 1990s, at least, as you reminded me. And so what are you seeing on the national level? What can we learn from national efforts?
Well, it's interesting. The messaging used to be, we're going to get a little warmer. It might get a little colder here. It was kind of a message of, it's about to come here. We need to get prepared. But it's suddenly here. And not only is it suddenly here, but it's suddenly here, as Sean said, in extremes. So extreme snow, extreme rain, extreme heat, and in communities that have not yet been prepared for these extremes. So if you're living in North or South Carolina, and it always gets a little warm in the summer, certainly, but you don't have a lot of air conditioning. You're comfortable with the summer breezes, but you're not prepared for prolonged 90-degree temperatures. Or if you're in Texas, Texas is hot. I trained in San Antonio, but they're not prepared for prolonged 120-some degree temperatures. And even places that have historically had that kind of heat, like Arizona, the character of it is different. So these sudden extremes make it a big difference. I think what's also happened is that even in places where politically in the past they were not prepared to talk about climate change, and they may still not use the C word, they certainly know that the weather has changed, that the environment has changed in such a way, realizing weather is different from climate, but it's changed in such a way that they now have to prepare for these extraordinary events much more often, which impact huge swaths of the population at the same time, but with disparate impact. So we formed at APHA a Center for Health, Equity, and Climate a few years ago in order to try to focus on honing our message on educating the public, educating policymakers. We've always had this huge advocacy machine to try to advocate for funding, particularly for climate and health, but also to try to get many of the people that are involved in the financial aspect of climate to recognize that they needed to invest. And while we love the polar bears, we're worried very much about the glaciers melting. But at the end of the day, the question is for what? And the for what is to protect human health. And then when you look at the fact that today, you go back 4 or 5 years, we've had several severe storms in our country. People are still recovering from those storms. We still have people under blue tarps in Texas, in Louisiana. We still have people in the New York area still recovering. Some of the academic centers are still recovering from the big storms they had several years ago. So understanding recovery is slow. People who have money recover faster, but not often as complete as they would like. And people who don't have the resources recover very, very slowly, and in some cases never recover. And so I think that's the kitchen table issue we want people to understand, that the imperative today is to do something today about this.
Yes, thank you. And again, thank you for APHA's leadership on this. So obviously the urgency of this, the climate crisis and its human health impact, and perhaps some priorities that we might think of. So what in your, each of your opinions, what are the areas that you think need to be addressed more immediately? And then what might be some of the challenges and opportunities to make, advancement on the progress?
Well, let me start. I mean, obviously on the adaptation side, and John can give a much more detailed explanation of what on the ground looks like, but response planning, being much more proactive. Many years ago, public health finally got into the business of, figuring out where to identify people who required supports, the people that were dependent on electricity to live on a moment-to-moment basis that were in the community, and identify those high-risk populations and make plans to move them around. All those kinds of things as part of preparatory planning have certainly been done, but we've got to think about doing those on the no-notice events. That's the real fear here, is when it happens overnight, how do you respond quickly? I think the second thing, of course, is adaptation for the long haul. So one of the things that we've gotten into at APHA is smart surfaces, and trying to recognize that, urban communities, particularly lower income communities, can be 9 to 10 degrees hotter than more robust, more resource communities, because there's less green space. People have not paid attention to those places. They have a lot of dark impervious surfaces. They don't have access to air conditioning, again, for economic reasons. The fact that their electric costs and the utilization of electricity tends to be much higher, both the cost and the utilization in those lower income communities. And then, of course, the resources to pay for that can become a resource that impoverishes people. So thinking about that proactively to make sure that people can afford to get air conditioning. Now, air conditioning has its own challenges by exacerbating climate change. I understand that, but cooling them acutely is important, and making sure they know where to go, how to get access to water, where's grandma, how to look after each other, all those kinds of things, and then proactively, how do we lighten those communities with lighter surfaces, new road surfaces. The Biden administration has their infrastructure grant, and that's great, that money is going to go out the door. But I keep arguing we want to make sure that money goes out and gets spent in a way that is healthy for communities, so that we build those communities smarter, more healthy as we go along. So it's good to have billions of dollars, but if we build the stuff that we built the way we built it before, we're going to get the same result, which is not as healthy communities as we would like.
Thank you for that. And to your point, actually, NYAM is going to be hosting a conversation that Congressman Espaillat has set up with HHS Secretary Becerra about the Inflation Reduction Act, which does give some funding, as you point out, for this sort of green energy transition. But really, we do need to be thinking about the health implications and planning as that all goes forward. Dr. Vassan, of course, you've been thinking about this and just specifically to the heat issues. NYAM's been working with the health department and CUNY to do some mapping around heat vulnerability by older populations in the city, throughout the city. We're also, to your point, Dr. Benjamin, about follow-up and slow recovery, we're doing an update of the Superstorm Sandy impact resilience report, many years after the fact. We're checking back in with those communities about the lingering impact. So yeah, I appreciate your point about the slow recovery. But Dr. Vassan, what do you see?
No, I mean, so much of this is salient. I was a practicing hospital physician during Sandy and can never forget traveling into the hospital when the entire lower half of the city was blacked out, and then seeing patients in hallways and in the foyers of our hospitals. And it really a challenge. I mean, this is to the point that George has made. These no-notice events are becoming more and more extreme, and preparation is key. But let me give you a little bit of a sense of what we have done. And when I think about and what we are continuing to do, for the health department and for the public health system in the city of New York, we are very much positioning ourselves, as we have been, maybe not formally so, as the health strategist for the city. And what does that mean? That means we're not always leading. We're not always in the driver's seat of planning these approaches, but we can put a very fine point about what are the real world impacts on human lives. We can do that through data. We can do that through innovative community programming. We can do that through mapping, as you described. And of course, we can do that through preparedness. Where can we invest in communities in advance of no-notice events and extreme events so that they are more resilient? But it is also working within a much broader climate and resiliency plan for the city. So we have had from the Bloomberg administration, the Plan YC program, which is a updated interagency, citywide health, really with a very strong health focus, but very much takes into account, basics of infrastructure, the ways in which we invest and particularly overinvest in historically disinvested communities to build up their preparedness, because there has to be much in the way that structural racism was intentional by design. We have to make anti-racist policy intentional by design. And that means, where does the money go? Well, how do you map that? What are the zip codes? What are the neighborhoods that get the dollars to build back up the infrastructure and resilience that they never had? But the health department specifically does quite a lot of work in a few ways. Air quality, just as an example. We have the largest urban air quality survey in the world, called the NYCAS, New York Community Air Survey. And that is in concert with and in support of the statewide environmental health and air quality monitoring that the state of New York does. We have put air quality sensors, millions of them around our city, at lower level locations, so we can get to more micro-targeted effects. We can look at the impact of truck traffic and commercial char broiling and industrial pollution. And it really gets down to those areas of environmental justice, to George's point, why certain communities can have temperatures that are 5, 6, 7 degrees hotter than others. And it comes down to shade cover, green space, and other forms of infrastructure, as well as pollutants. We've used NYCAS over decades to really drill down on and to put into our health code very clear policies around things like truck idling, things like commercial cooking rules. And you don't really think about that as having an impact on your everyday life, but it does in terms of improving the overall air quality. Let's talk about extreme heat. You mentioned the work that we've done with CUNY and NYAM. We've created a program called Be a Buddy, very much informed by the lessons, the hard lessons from the 1994 heat wave in Chicago, where socially isolated elderly Chicagoans were disproportionately impacted and many died, hundreds died. And what did we do? We have come up with a program that not only pairs elderly, isolated, potentially isolated people with younger people to ensure that there's someone knocking on your door checking in, but we came up with a home energy assistance program where one can apply for an air conditioning funded by the city. And as Georgia said, we can use it to provide that acute cooling effect that people need. And we've distributed, I believe, over 300,000 or more air conditioners around the city. And then we've built cooling centers. We know that there are people who can't afford or don't have the housing conditions or live in shared or congregate settings and can't manage to control their own indoor air environment or temperature environment. We've set up cooling centers pre-positioned in communities with worse underlying air quality, but also worse, more extreme temperature vulnerability through our heat vulnerability index, which we also measure using similar sensors around the city. So it's a real convergence of local environmental health, which has a long tried and true history in public health, and then this extremity and consistency and frequency of extreme weather caused by climate change, and really does hopefully help draw the thread from that very local effect to this global challenge, which for a city or for even a health department can sometimes feel hard to get your arms and your head around.
Yeah, and the climate justice underlying thread has to be pulled through all of that work, which you gave some great examples of. You know, there's always this conundrum of public health. When it's doing its job well, it's largely invisible, right? Because prevention is happening, surveillance and food quality, et cetera, is all working. So what might we do, or what has been effective to try to get the larger public really to join us in addressing the climate change and public health crisis? How do we win those hearts and minds and engagement to support the work by public health?
Well, you know, I think from my perspective, the first thing we ought to do is take credit for things that are happening in which we are engaging. And far too often, terrible things happen, we get involved, and then we're so busy doing the work that we don't take the credit to the extent we're involved and share that credit with others when they need to. So, you know, the terrible air quality that we had, that was a public health crisis. And yet, you know, if I was, you know, had the opportunity being at EPA or being at HHS, I would have been telling the world that this was a public health crisis, and I would have been talking about what public health was doing to address that. When we had the terrible train derailment in Ohio, again, you had EPA and CDC going door to door, providing extraordinary support for people to protect them from hazards that they may not have been able to see, that may have been still in their homes, may or may not have been, but they didn't know. Again, letting public health be visible and people understand that they're being protected by public health work. And then the other thing is being more proactive about the things that don't happen. I know it's always difficult to shell a negative, but you can sell it. You know, if you go to any work site, and you know, I love New York. You know, you may know, I spent about 6 months there as a fellow at the Roosevelt House Public Policy Center. And as I was walking around the city and looking at some of the construction going on, I was always amazed at the signs that were there that said, you know, 2 weeks, no injuries, right? Public health needs to, when you haven't had foodborne outbreaks, when you haven't had bad things happen, let's have a campaign to tell people nothing happened today because public health did its work. And so that coupled with a positive campaign that talks about what we are doing, I think we'll do a better job of letting people know what we do and that their tax dollars pays for this work.
I couldn't agree more. And, you know, the we cannot underestimate how much reassurance we provide people as public health leaders, particularly as public health leaders who have, frontline experience caring for people. People want to hear from us and they want to be reassured, especially when it's an evolving situation, when it's, rapidly changing. One of the criticisms of the COVID response was that we didn't consistently enough say that things were changing and that the information is what we know today. Stay tuned, things could evolve. But what it said time and time again is that people were listening. They were really listening to us because they were unsure and they needed guidance. That was brought home once again just a couple of weeks ago. Public health was very much in the crosshairs, front and center about, should I go out of the house? What's the impact on my health? What's in this? What is PM 2.5? Where did this come from? How do I protect my loved ones? We got down to the level of saying to providers, healthcare providers, cancel your patients, switch them to telehealth, especially your vulnerable patients, right? That's the level of, impact we can have. And I couldn't agree more with Georges. We leave so much on the table in terms of telling our own story of our impact because it is invisible, but we are keeping people safe every day through it's essentially a safety net of public health, right? We are preventing bad things from happening every single day. And when bad things happen that are unexpected, we're stepping up and responding. And I think that that's a story we need to tell much more consistently in myriad ways, because what it's coming down to now is, right, the pernicious debate coming through out of COVID is public health has too much control, has too much authority, and that authority should actually be diminished. I would say the exact opposite. Public health's not so much from an authority perspective, but from an impact, from an influence, and from a storytelling perspective. We don't tell our story consistently. We don't tell our story often enough, and we aren't loud and proud in the way that we tell it. So often, my agency even, we talk about our work through our community partners. And I keep telling even my team, it's like, wait, didn't we fund that work? Didn't we design that work? Isn't that work that we did? Like, we have to start talking about the work of government public health as at your doorstep, in your face, in the same way that our hospitals and our care delivery systems are in your face and very visible to people. Because right now, the American public, and even in New York, is confused. Like, they don't know what's what.
Yeah, I'm totally in sync on this. In fact, the first roundtable session that we did on this theme of climate change and health was entitled Telling the Story, that we really do need to tell that story, and that we as public health professionals and other health professionals and providers do have trust and credibility that can be leveraged to support everybody's concerns about their loved ones and their communities. So I just want to close out by thanking you so much for both of your time today. I know it's very stressed and precious, and you have a million things to address, and you're doing that while also addressing the climate crisis and health, and for that we're grateful. We have a number of resources, links, and information on our New York Academy of Medicine website related to this discussion specifically, but I want to just close out by asking you each, what do you feel are the 2 to 3 things, or maybe just the one thing, that we can do as individuals or as a collective?
I think there are 2 things you can do. First of all, you can do things to lower your own carbon footprint. I think that's very important. And I think the second thing you can do, of course, is just prepare for emergencies. Know where your family members are, have a plan. All the stuff we learned, when I was a Cub Scout, those of you who are Girl Scouts, all those things we learned about preparation are very, very important as part of preparing. And I just encourage everybody to do that stuff.
Thank you.
Yeah, for New Yorkers, for Americans, it's educating yourself and making yourself aware of risks and what to do when conditions change, particularly rapidly. Now, air quality index, which to my colleagues in California and in Oregon, that's sort of, table stakes. And in fact, I was on the phone with them first thing when this started. But for the rest of the country, and certainly for the Eastern Seaboard, this hasn't been an issue in this way. Getting engaged, getting aware. What do these numbers mean? We are going to do our best to put that information out there, but New Yorkers and Americans really need to take that information and say, okay, I know how my underlying health is. These are the choices I'm going to make, armed with the right information. And that gets also to preparedness as well. You know, I know where my living conditions are. I know that I might live in a low-lying area and I'm at risk of flood or I'm prone to heat. I'm going to prepare. But and creating emergency plans around these events are going to be increasingly important. Extreme heat events, what am I going to do? What's my family going to do? Who are the calls I'm going to make? Down to that level of granularity so that you can just leap into action when something happens. But the second piece, and you know, I hope it'll resonate with Georges as well, because I know their APHA does a lot of advocacy on this front, is vote. You have to vote. You have to vote for candidates that believe in climate change. You have to vote for candidates that believe in public health and that are willing to put their time, their effort, their advocacy, and their legislative agenda and resources behind it in their communities. Because the cost is, we're all connected by this, and the cost of having even elected officials in close proximity to one another with very widely divergent views is really keeping some communities unprepared and some communities much better prepared. And that can't happen, right? Like this is too universal an experience. This is superhuman. This is existential. This is about the health of this planet and by extension, the health of every single living creature on it. And we have to feel a sense of connectivity here, but we have to vote. We have to vote for leaders who are willing to resource and speak to these issues in very real ways that affect their communities. Otherwise, we will have this patchwork that we continue to have.
Commissioner Vasson, Dr. Benjamin, thank you both so much for today and for the work you do. Be well.
Thank you.
Thank you.
We're really grateful to Dr. Benjamin and Dr. Vasson for the insightful and informative discussion on the key role that public health systems and public health workers play in addressing the impact of the climate crisis on our populations and communities. Let me see if there's a few key themes that came forward from what we heard from their rich conversation. They talked about the fact that there are more and more no-notice events, meaning not a lot of preparatory time events like catastrophic smoke in the air that can affect everyone. And so there is often in these cases people turning to public health systems for guidance. So we do need to be able to tell that story about how public health is absolutely crucial to protecting the health of our populations and protecting all of us. Dr. Vasson pointed out that reassurance that public health can provide even in these immediate crises without much notice is really immeasurable. The importance of preparedness related to that as well, both made that point, being ready and having plans, even as individuals and family members, about how we will address various climate-related health crises. The importance of having more input from marginalized communities in particular. Heat as one example, how unfair is it? And of course, how dangerous is it that some neighborhoods, some workers face temperatures that are 9 to 10 degrees higher than in other more resource neighborhoods. And of course, we need to address that as an equity problem. Dr. Benjamin made the point about there's more extreme weather events. Of course, weather, which is more of a daily occurrence, is different than climate, which is the overall trends in temperature. But that was important to point out as well, that we need to be putting in place in an anticipatory way as well as an after the fact way resources to focus on especially those communities that have been hardest hit by climate change related events. Dr. Benjamin made the point that often the recovery is very slow and sometimes even non-existent. We still have people in blue tarps, for example, years after, months and years after extreme weather events. So we need to prepare better. We need to invest strategically in those most vulnerable communities. We need to build smarter particularly as there is now investment through the Inflation Reduction Act in the green energy transition, as we build roads and as we build parks and as we build infrastructure, that we need to have community input to make sure that that is climate ready and will make some moves towards just better equity. Dr. Benjamin talked about equity when they set up the Climate Change and Equity Center some years ago at APHA. The question was, why are we doing this? He said, the answer is because it's for human health. Thanks to both these leaders. Thank you for taking the time. Do take a moment to click on the resources link on our page, webpage, and find some additional action points and education resources for your own journey to address climate change and health. Be well.